Okay, so you had a great, stimulating opening from 3 speakers. Please think about your reflections and ask questions. That's why we're all here, so that we can get the most out of this forum. Mary Jane, do you want to start?
Sure. First, thank all the speakers for really great talks, but I'd really like to focus my first question for Kelly. So I sit in California, pretty big state, and had thought the Accountable Care Act, and we're going to have oversight organizations, this is going to be our funding stream into integrated care. But in fact, at 6 schools that I work with, every family is randomized into 8 different payers, 8 different accountable care organizations. Could you tell us a little bit how you got one accountable payer for all children's services? Like, what kind of miracles did you have to do, and how did you get that done?
I think that's a really good question. In fact, I was in Orange County last week talking to the Children's Hospital of Orange County about their 160,000 IPA, Independent Practice Association, and the business model there. And there's actually a need for the hospitals to partner in a way. So the Ohio Children's Hospital Association divided up the state and said, we went to the governor and said, we will try to guarantee X% savings if we can really do this in a geographic region and have all the social agencies partner with us. The United Way came together, the schools came together and supported it. I mean, it really took a lot of time with the governor and the mayor and other people. But I think once people saw that kids were different and that pediatric exclusivity was really a value to the state Medicaid director, who was a pediatrician, it all came together, and that really it allowed us to go across geographic boundaries like that.
Hi, great talks, great panel. My question is sort of similar, I think, or a follow-up to what Mary Jane was talking about, and it has to do with the system hydraulics that I'm really worried about when it comes to paying for prevention. So I buy this idea that we've got to have payment reform and accountability. That makes perfect sense. But the way in which you're doing it, Kelly, the way in which you've been talking about it, Eric, it seems like it's working. So you've got hospital-based network with an outreach to social services, and you're able to help pay for some prevention services. And Eric, what you were talking about was the way in which states are targeting those high-cost, high-risk kids and then capturing those savings. But my worry is that sometimes that's very difficult to do. In my state, New York, and in others, you can target those high-cost kids and capture savings, but be damned if you're going to get that back into prevention, which is going to mean going into schools, it's going to mean going into primary care, it's going to mean going into homes. So how do we think about the system hydraulics when there are so many of them, and prevention is often in places that are outside the places where these pay-for-performance may actually be effective?
Well, I personally believe that you don't necessarily start with mental health. I mean, we started with infant mortality because prematurity was so expensive, and obviously it was a driver to every self-insured corporation. All the corporations lined up and said, we want to focus on infant mortality. And infant mortality is mom and apple pie and all those good things, and everybody could rally around that. But when you start to focus on infant mortality, you have to go into neighborhoods and prevent violence. You have to go in and find jobs for people. You have to go in and do early childhood things. Infant mortality is a prevention thing, and the mental health stuff comes with that. So we actually saw that as a great opportunity, and we didn't couch it as we're coming in to prevent mental health problems. So I don't know if you guys want to weigh in on that.
I think from our perspective, around the behavioral health needs of kids and the expenses that are incurred by some of those congregate care options that could perhaps be avoidable with better coordination of care, more evidence-based practice, and so forth, is a very tough nut to crack. One of the states that I profiled up there was the state of Maine. They reduced their Medicaid expenditures by 44% by implementing care coordination and a few carefully selected evidence-based practices. As soon as the fiscal crisis hit, the entire program was dismantled because of a small line item in the state budget that was producing primarily savings in Medicaid dollars. So it's incredibly naive of me to say, because I don't really quite understand the mechanisms. But how is it that we can save all of these Medicaid dollars and not have there be some sort of federal initiative or approach that might do that kind of reinvestment is the question that I would ask. Because despite the state investment being relatively small, they had to cut somewhere, they said, and that was the thing that was easy to do because it was not a mandate on their system to be providing that kind of care coordination, and the savings was primarily around Medicaid dollars. So I don't have the answer.
Okay, thank you. I would like to follow up with a question for Kelly. I'm very intrigued by the emphasis you gave to the business model, and in particular, the intensive data collection that you emphasize as one of the key components of the business model. I would appreciate if you can elaborate a little on that point about like how the data was collected in the systems, what you found them to be useful for, and any challenge or barriers or any lessons you learned that might be useful for other applications.
Yeah, thank you, Naiwa. So that there's three kinds of data that we use on a regular basis, and you have to have your claims data so you know where your costs are and where the patients are, and your eligibility files. That's really important, and no system, any prevention system that doesn't have that will never be able to make the cost argument. The second piece is we actually use electronic health records to find children at risk, children that are trending the wrong direction, children that are starting to show patterns that are concerning, families that are showing up in the emergency room for lots of minor trauma because they're often child abuse cases or kids at risk. And then the third thing we do is we actually build, so for example, we provide no obstetrical care, but for the Greater Columbus Infant Mortality Commission, the OB hospitals, we built a database registry for all providers to enter their progesterone and immunizations and long-acting contraceptive data into a system so that there could be a common community platform that we could analyze for quality of care. And then the last piece is on small projects, quality of life projects, we actually administer, like for the kids with G-tubes, we administer activities of daily living scales for some of those kids and satisfaction surveys of stress things for the parents, because it's the parents that are really driving the emergency room visits and hospitalizations and the quality of life for the family. So we only do those things, though, on select subsamples to try to change practice.
Thank you.
Yeah, hi. I'd also like to thank all the speakers and thank the organizers for making this program available to interested members of the public. I just have a comment. Obviously, it's a huge problem, many huge problems, but one specific huge problem that was pointed out is the very high cost for hospitalization and congregate care for mental health. And certainly that's true. But a couple things. Clearly, the users of those services are not a random sample. They're the ones who need the most service, whatever we do. The other thing is that congregate care and hospitalization are not, monolithic things. I've worked in both facilities, 16 years at a residential center and about 10 years on an adolescent inpatient unit now at University of Southern California. I think it's been very clear for a long time that congregate care needed to reinvent itself, and it is doing so, but only in a very slipshod way because of cost containment ideas and generally pretty naive ideas. And inpatient hospitalization, I think that, with the exception of the one study by Hengerler et al., where they compared it to MST, I've seen almost no study of the value of inpatient hospitalization. I think it's really time to look at, is that the best place to treat acutely disturbed, psychiatrically disturbed kids? I think it's an open question. They're not the same as medically ill adults. They're not the same as medically ill children. And then just a last, I'd be interested in comments, and just a last thought with regard to being able to bill for trauma services. It's true one can't write complex PTSD, although I encourage my residents to do that in quotes. But I've rarely met a kid who was sufficiently impaired by trauma, whether it's complex or simple, who didn't also meet the diagnosis for something else. Unfortunately, the DSM allows us to list multiple diagnoses. Unfortunately, people who review the charts don't really know the DSM exclusion rules, so we can use less specific diagnoses sometimes for something more specific and get paid for it.
So I'll weigh in on the trauma run. While I totally agree with you, I think I'm trying to make 2 points. One is that the federal standard for treatment is medical necessity. Typically, the states define medical necessity by having a diagnosis, right? So under medical necessity, you could meet a child's trauma-related issues without giving them a diagnosis. So in theory, the federal policy would allow that to happen. The state law makes a different distinction. But here's the second point I want to make, which is that there are a ton of kids that walk around with co-occurring issues in foster care. But the tendency is actually to treat them for the diagnosis that they have. And so the question becomes, if you have to use a diagnosis other than what the child actually has for the purposes of getting them treatment, how often then do you also rely on the specific treatment protocols that relate to that diagnosis? So most people would agree that the level of ADHD diagnosis, conduct disorder and oppositional defiance, and depression and generalized anxiety all exceed what you would expect from any vulnerable population, specifically looking at kids in foster care. So the question becomes, if children are being treated for those diagnoses instead of trauma-related issues, then they're probably not getting the care that they need. So that's the point I was trying to make.
I think it comes down to supervision and just being able to work within the system. Giving a kid one of those diagnoses and saying, still, we need to address the trauma system.
Yeah, I just think it is. That's right.
Hendricks Brown from Northwestern. I thought these were really wonderful presentations, and I have a question about the scalability of the kinds of infrastructure that you guys are talking about. So in 2 states, in Ohio and Washington, there were some really innovative models for this one. It's not, 2 out of 50 is not a great record yet. And so one of the questions is, what's this next stage? And I thought you folks were really laying out a whole bunch of principles about, where could the cost savings come from? How could they be reallocated in other settings? I wanted to get back to this issue. We didn't talk too much about the public-private partnerships. The federal government has a small business administration. And it seems to me like a really successful kind of model for this one. Is there something like a prevention administration that we could think about, one sort of a structure where the federal government could help and support and lead states into a direction that might be in their self-interest?
Well, I think Hendricks, there are several aspects that the federal government would really grow the field rapidly because the market is ready to move. And there's consolidation happening across the board. Hospitals are being consumed. The Children's Hospital Association is 200 institutions, and no one thinks it's going to be more than 150 in 5 years. And there's just huge consolidation happening in acquisition. But in the short run, if the federal government were able to help state Medicaid directors with what are the indicators, number of kids that are staying in school, number of kids that are placed out of home, number of kids, if we get the right measures for the state Medicaid directors and say this is what an accountable care organization really has to do for kids, I think that would be huge. The telemedicine standards, having national standards for children to participate in prevention would go so, because I have to go beg the Medicaid director to change their regs, and they say, well, no one else is doing that. There's no guidance from the feds. The Institute of Medicine's silent on this. What are you saying, Kelly? So we need some kind of guidance on structure. I don't know that we need true dollars and other. I would love that, but just structure more than anything.
Yeah, I would agree with that. I mean, one of the things that's been kind of frustrating is we, again, like Kimberly Hoagwood here in the front row, second row, and myself have always been interested in the question of the diversity of approaches that states have taken to try to scale up and move the needle. And again, if you've seen one scale-up effort at a state level around prevention and intervention of mental, emotional, behavioral disorders, you've seen one effort. The diversity is extraordinary, and so in some ways that's great. It means that there's local laboratories figuring out, or each state's a laboratory. Within states there are counties and ACOs that are laboratories to try and figure out what the mechanisms might be to move the needle. But we need, as Kelly is suggesting, a little bit more structure, more guidance that would help us first measure similar things that matter across states so that we could then leverage that information to, into a learning community nationally around what are the things that you've been doing to actually achieve those kinds of changes. I mean, the HEDIS measures for behavioral health in kids, there's only 3, I think, right? I mean, it's
terrible.
And I think there are things like, there's just how quickly were you connected to community-based care after hospitalization? How often is your ADHD medication managed, right? And I think there's one other. We're not asking the hard questions and asking states to report up consistently, even things around penetration rates and what kind of services are being delivered. So we have no basis for understanding what strategies seem to be working to move the needle. Even just that kind of consistency in expectations of measurement around real-world things we're trying to achieve would be a huge step.
So one of the approaches that we took at ACF was to think about the work around improving child-level outcomes as having to follow a similar path that the child welfare agencies followed in building their capacity to get more children back home or to get them to adoption and guardianship. So you saw that when that law was passed, there was a very limited capacity to do that. As states got more experience doing it and learned from others, they got increasingly better at that. So that states today are more competent in anticipating the safety and permanency needs of children and then putting in place policies and practices that get them there. So our idea was, or our basic premise was that, particularly from a child welfare perspective, until agencies had the experience of doing this work and saw the benefits of doing the work, it would be difficult to hold them accountable for the outcomes that the work was intended to produce. So we took all of the discretionary funding opportunities we had and focused them on the introduction of evidence-based interventions and the infrastructure to support those interventions in child welfare. So we did that work around substance abuse, treatment and trauma for children and families. We focused it on mental health needs, and then we also made some investments around school-based interventions, all on the premise that folks had to get exposure, familiarity, and build capacity over time. And then I probably would argue the biggest movement we made in that direction was that Congress allowed HHS to provide waivers to states to use their Title IV dollars differently. Title IV is the largest funding source that goes to state child welfare agencies to support out-of-home care. And the federal waivers allowed states the flexibility to use those dollars both for children who were in care, but they could also use those dollars for children before they came into care or as they exited to ensure that the exit was more successful. And so many states were attracted to that initiative because of the flexibility. We took 2 steps there to push the field along, which was one, we required that the state introduce at least one evidence-based intervention with the goal of scaling it up to the capacity necessary to serve the system. So just trying to get people in the ball game. And then the second thing we required was that the rigorous evaluation include an evaluation of the child and family level outcomes so that states could both see how to do these interventions and how to get better at them, but also see the benefits by seeing evaluations that demonstrate whether children are making progress or families have more capacity to care for their children than they had before they entered the system. And we're hopeful that that's the place where we'll really create knowledge and anchor a movement going forward around using evidence. So there are about 20 states that have those waivers today, and then the HHS has the authority to grant waivers to 10 more states. So you would imagine that, a year from now, roughly 30 states at a child welfare agency level are focused on learning how to effectively implement and monitor these EBPs, but also evaluating the effectiveness of them so that they can also see the benefit at the child and family level.
Excuse me, I'm Bill Beardsley from Boston Children's Hospital. I'd like to add my voice to the thanks to you all for this extraordinary panel, and I'm also introducing the next speaker in about 2 minutes. So I will frame a question which I think is vitally important for the forum that we won't have time to answer, but if we think about population health and...
So why did you let me stand here?
Yes. and I'm also doing a project with David. But if we think about population health, then we have to think about how to bring the same standard of care in every state. And Illinois, Washington, and Ohio are leaders. There's some ways in which Massachusetts is a leader and Massachusetts is a laggard, but again, they're 4 very different configurations. And how we think about doing this, I think all politics is local, I think all healthcare is local. And the fact that Medicaid is administered by states means that it has a huge impact. So how we think about bringing the innovations to scale for everyone in every state is really one of our, I think, important tasks. And I thank you.
So please thank our panel, please. And Dr. Beardsley is going to come up. Thank you.